Good afternoon, everyone. I'm Catherine Brookman, Associate Director, Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar given by Tilak Dutta on training caregivers to use safer patterns of movement with PostureCoach. We are grateful to the Ministry of Labor, Immigration, Training, and Skills Development for our funding, which supports the delivery of these webinars, and to our presenters who provide their expertise. CRE-MSD has recently switched video conferencing platforms and is now using Zoom to host webinars. Please bear with us should we need to address any technology issues today that occur during the webinar. This webinar will be recorded, with the recording being made available to you on our website, along with the presenter's slides shortly after today's webinar. Participant names will not be visible in the recording of the webinar. The format of today's webinar is as follows. The presentation will be given, after which time we will have 10 to 15 minutes for a question and answer period with our presenter. Please refrain from using the raise hand button, as we will not be monitoring this feature or any other meeting reactions. During the question and answer period, we ask that you type your questions into the chat. The chat feature can be pulled up on your screen by selecting the chat button in the control panel that appears near the bottom of your screen. I will relay these questions to the presenter or a similar question should we have duplicate themes. Your video is disabled and you will be muted for the entire presentation to ensure there is no background noise disruption. Should you have a pressing question, however, or a technology glitch that cannot wait until the end of the presentation, please do type this into the chat and we will do our best to address it right away. After the webinar, you will be sent a link to an evaluation. Please fill this out, as it will assist us in the future delivery of these webinars. Thank you for joining us today, and if you have not already done so, please check out our redeveloped MSD Prevention Guideline for Ontario website at msdprevention.com. Now it is my pleasure to introduce to you our presenter today, Dr. Tilak Dutta. Dr. Tilak Dutta is a scientist at the Kite Research Institute, Toronto Rehabilitation Institute, University Health Network, and is an assistant professor at the University of Toronto at the Institute of Biomedical Engineering. He leads the engineering health team, whose goal is to give individuals with disabilities and their caregivers the tools they need to live independently in their own homes. The three specific focus areas of his work are preventing falls, caregiver back injuries, and pressure injuries. Now it is my pleasure to turn this over to Tilak.
Thank you so much, Catherine, for the lovely introduction. Thanks to everyone who's joining us today. I see a nice big group. I always love to know who's in the audience, and I was wondering if for those of you who are comfortable with it, if you just want to type in the chat what your kind of role is, what your interest is in being here today. If you're a practitioner, if you're a healthcare worker, if you're working in a different industry, yeah, I'd love to. I'll move on with the presentation, but if anyone wants to put that in the chat, and just so we know who we have in the group, that would be great. Thanks. Yeah, so this presentation is about PostureCoach. It's a project that our team has been working on for many years. Oh, this is great. This is a great group of people I can see already. There's a great cross-section of different backgrounds here. Excellent. Yeah, this is something we've been working on for many years. We've been kind of limping along, getting little bits of funding from different organizations, little bits of seed funding, most recently, thanks to CRE-MSD, their seed funding program. But it's been a bit of a challenge keeping this project going. And each time we, kind of test a version of PostureCoach. We're up to a fourth version of PostureCoach now. We kind of find limitations with the existing version, and we think, is it really worth pushing forward with this idea? Is it useful? And every time we show it, something comes through. Someone with experience with back injury says, where can I buy one? Like that, people seem to get really excited about this project and they want to see a product like this out there. But with the group that we have on the line, what I'd like to ask for your help with today really is, as I go through and describe some of the work that we've done with PostureCoach, is to help help our team be critical of this thing and really decide, is this something that we need in the market? Is it something that that if you're a practitioner, if you're an occupational therapist, a physiotherapist, clinical nurse educator, whoever you are, if you're in research, can you see this as a value? Can you see this as a useful tool? Bottom line, would you buy one of these things if it was out there so that we can decide, is it really worth putting putting more energy into this thing? I think everything that we've done so far shows that there is promise, but maybe we're not seeing something that's really obvious to other people. So, today I want your help if you're willing to really kick the crap out of this idea with me. What's wrong with it? What are the practical limitations if we want something like this in the field? What are the things that we're missing that we might not see that would prevent this from being a useful tool? So with that, I'll just start with a video that features one of my PhD students, Dawood, who developed the latest version of PostureCoach. And he kind of gives the problem that we're trying to solve and the latest version, how it works. It demonstrates it. So I'll just play that, and then we'll talk about it.
Low back pain is a huge problem for healthcare workers. A paper published in 2020 found that over 70% of workers experience low back pain and half experience severe pain daily. So we've developed a tool called PostureCoach to help address this problem by helping to shift these workers to using safer patterns of movement. It does this by providing a gentle vibration or audible beep when the user flexes their lumbar spine too far.
All right, Hamid, so we're gonna first take off just gonna adjust here. I want you to lift your leg up for me here.
Our studies have shown that people without any caregiving experience wearing this system for about an hour a day for 2 days is enough to significantly reduce the amount of lumbar spine flexion they use. And this shift in behavior is retained even 2 months later. This is our latest version of PostureCoach that we should be able to sell for about $100. To use it, you simply attach the first sensor to your belt and attach the upper sensor to your clothing or this strap. The user then needs to press calibration button while standing upright. Now the device is ready to provide the user feedback in the form of a vibration or an audible beep by setting these switches. There is also a dial on the side that can be used to adjust the threshold for when the feedback is provided. We think PostureCoach is a simple tool that can help caregivers avoid back pain, which has a double negative impact on our healthcare system because it not only requires a new caregiver to replace the person who is experiencing pain, but it also creates a new patient.
So that gives you a big picture of the project, I think. Does anyone have any burning questions, feedback you want to give right now? I mean, I think if so, you can type stuff into the chat. I'm happy to kind of take questions as we go forward here. I'll keep an eye on the chat, and Catherine, I'll ask you to maybe you can relay questions if you see something come up. I'll continue here.
Will do.
How much is it? $100 Canadian? It'll be that's a great question. the current version costs about $200. Yeah, it doesn't do anything with twisting movements. It costs about $200, we think, to make the current version. We'll probably have to sell it for, let's say conservatively, $400 to make it a meaningful product idea. Looks simple to put on and use. Thank you.
So Tilak, I just want to be clear to our participants, CRE-MSD, we're not endorsing this product, and we're not saying, you know, we're having Tilak here to present this product so you'll buy it. Tilak's presenting this product so he can share with you the benefits of learning, using this as a tool to learn proper body mechanics. And he is going to talk to us about how does the learning from using something like this stay? Tilak said it stays for about 2 months, but do you need to constantly wear it? And so he's going to share with us some of his findings, which help us look at what are proper body mechanics when we're moving someone.
Thanks, Catherine. Yeah. This is really, it doesn't exist as a product now. The questions I'm asking are really just as a like, should we pursue this avenue? Everyone, you know, opportunity cost. We all have only so many hours in the day. Is this a direction that people think would be useful? That was the goal here, and certainly, yeah, I understand that the limitations with how we should discuss that here today. Is the sensor triaxial? Yes, it's a triaxial sensor. Maybe we can go in with a bit more detail and we'll get a better sense of what we're trying to do here. I'll take you through kind of the evolution of this. We'll start with the problem. Emily King, many of you know her. She works for VHA now. She was a PhD student in our lab a number of years ago, and she had personal support workers come into this space that you see in the picture here called Home Lab, and they simulated a whole bunch of healthcare tasks. And it was very clear from her measurements and her analysis of these activities that there are many, many activities that put these workers at risk of injury, particularly back injury, many where people are bending and flexing their spine quite a bit. I'm sure people in this group are already familiar with the rates of back injury among this group, but just to this is part of some of the data that she collected. Quite a few people report that they have a previous, at the time when she asked this question, do you experience any previous injuries that still affect you? About a third of people said yes, and the most common type is a low back injury, low back pain. So in ergonomics in this kind of field, if we were in an industrial setting, the goal would be to fit the work to the worker, right? We would do that by changing the design of the work, the size of the things that people are lifting, give people better equipment. To some degree, we can do that in healthcare. We can use things like patient lifting equipment that reduces the load on the worker. However, for whatever reason, and there's other people like Emily who works in the home care industry, they might be able to explain. So far, we haven't seen this kind of approach applied. So giving home care workers the equipment they need, working with 2 people in that setting. You know, generally in a hospital or nursing home, you would require a lift like this to lift and move someone and to move them around. And you would need not only a lift, but you would also need 2 caregivers there. Most guidelines require that. Most organizations have guidelines that require 2 people to be there for all of these types of activities. And then if we contrast that to the way things are done in the home environment, you'll see that there's a big difference. There's rarely equipment like this available currently, and almost always it's a person working on their own. So, Stu McGill wrote a paper a while ago looking at the flip side, recommending the flip side of this. After we've fit the work to the worker, we need to start thinking about fitting the worker to the work. And so in 2009, he highlighted the importance of retraining the way workers move to try to further reduce the risk of injury after you've done everything you can to fit the work to the worker. So we're talking about movement training here, and our goal with PostureCoach really was one particular type of movement training, the type that's probably the most common when we talk about training for this type of work, which is to try to avoid flexing the spine. Rather, we try to bend from the hips. So hip hinging is, as it's sometimes called. We want to help people learn how to bend when they need to with a hip hinge rather than flexing their spine. And our goal was to see, can we develop a device that someone can wear that would allow someone to be able to train them to do that activity quicker than or in a better way than is currently trained. What this does, this is a picture from Stu McGill, one of his books. Why you want to do this is because of the hydrostatic forces that are generated within the intervertebral disc in the spine in the lumbar region. When you round the back, like you see on the right part of the screen here, the nucleus pulposus in the center, the jelly-like substance in the center of the intervertebral disc, tries to start working its way through the layers of collagen fibers that make up the outer parts of the disc, and eventually will start to delaminate, and this nucleus pulposus, the jelly-like substance, will try to work its way through those layers and come out the other side. We want to prevent that hydrostatic force from pushing the nucleus pulposus out the back by keeping the natural curve of the spine when you're standing. We want to maintain that curve and reduce that imbalance in hydrostatic forces inside the disc. So we do that using that by trying to avoid spine flexion, by trying to keep by trying to hip hinge as much as possible. So we want to test out this movement training approach. A quick overview, though, the problem is that we've had 5 systematic reviews recently that have highlighted that training doesn't work. I think it's important to just touch on this because we know that this is research that's out there. There were these 5 from 2007 to 2014. We touched on this topic. Tyson Beach and I did a talk on this, I think in 2020, when Denis and his team did a critical review of these five review papers to see what's going on here. There was a total of 77 papers that these 5 reviews found. The results after reviewing these meta-analyses, they found that the conclusions were that training doesn't work. Denis and his team looked at all this once more and realized what was happening here is that the meta-analyses didn't really consider the quality of the training programs. This is the problem. Instead, they were focused more on the quality of the evaluation. And really what the conclusion should have been to these 5 papers was that bad training doesn't work. So the question is, what does good training look like? Well, Denis in their paper, they highlighted a number of key things that should be incorporated within training to make it better quality training. And a key component of that is to have the training occur within the context that the work is being done, so that it reflects the realistic challenges that a worker will face when they're doing this type of work. And unfortunately, the way that personal support workers get trained is typically not like that. Typically, it's more of a classroom type setting where people are presented information. Sometimes there might be a little bit of hands-on work, but it's sort of simulated using the tools that are available in the room, like tables and chairs in that classroom are used to try to simulate some of these activities, caregiving activities. And it's not really the same as in the context of someone's bathroom, helping someone bathe or toileting, things like that you saw with the work that Emily did. So the problem is that we give people this knowledge in this setting that's not really matching the context where people are actually doing their work, and then we expect injury reduction or pain reduction And that just is not realistic. There's, if we want to teach this, we need to make sure it's happening. We need to think about how do we actually achieve that behavior change. We need to focus on how do we achieve the behavior change. And yes, knowledge is an important component, but we need to figure out how that middle component can be done more effectively. And so this is really the goal of PostureCoach, is something that you can wear, something that a personal support worker or a caregiver can wear while they're doing their work for a little while. It was designed as something that they would wear potentially for the first couple of weeks of their work, perhaps. And we don't need to wear it after that. The idea is that the tests that we've done in the lab have demonstrated if you wear it for a few times, you shift your behavior to learning how to hip hinge, and then you don't really need to wear it anymore. There may be need for future refresher sessions following that, but for now, the goal is to try to see if we can give people this this training in a short period of time and see if we see that behavior change. So we started going through versions of having this idea work. The first version used these sensors called shimmer sensors. These are triaxial sensors so we had one kind of on the upper back, one on the low back area. And these sensors communicated by Bluetooth to a smartphone. And the idea was we wrote a program on the smartphone that would cause it to compare the angles that the system was detecting. And then the phone would vibrate or beep if the person was moving the wrong way. This was actually designed initially it was like a internship project, a 4-month internship project. Mark Semple helped, I'm forgetting the name, the guy's name is on the next page here. Justin Wee was the intern student that was working on this, and Mark Semple was helping to bring it home. And as someone asked earlier, we were looking at both spine flexion, all three: spine flexion, lateral bending, as well as twisting. What we quickly figured out is that the sensitivity in these sensors doesn't really make it possible to detect the smaller kind of magnitude of the changes when you're talking about lateral bending or twisting. The overall bend, the amount that the two sensors shift relative to each other is not as much. And so it became harder to detect those things. So we thought at first we would focus on spine flexion. If spine flexion works, we can go back and refine and try to train systems to do the other two. And probably our gut feeling was that trying to do it all at once, trying to give kind of warnings to the user if they're doing any of those three things, would be difficult for the person to understand which thing they were doing wrong. And so to simplify the feedback and to simplify the learning process, we decided to focus on spine flexion, as again, it was the one that we found in most training programs where, the most commonly trained activity. So this is a video where you can see the sensors talking to the computer here. And you can see that it's detecting side bending to some degree as well, but we got quite a few false positive kind of vibration things happening. But you can see how this was our first attempt really at getting this to work. The biggest problem, I'll just share the data. I see some questions here. Hang on, I'll just quickly scroll in here and see. For in-home caregivers, each home would be considered a new environment, different dynamics. So it would make sense to me that in each new work environment. Oh, that's a great point. Yeah. Sean, I'm a bit worried that vibration-based perturbation could also startle the worker in awkward postures, causing them to attempt to alter postures. Yeah, there is and Bessie has the same concern. Bessie did, that we did notice this issue to some degree. Initially, when people are first introduced to the device, it does startle people a little bit. and it does take a little while to get used to dealing with the feedback, definitely. But what we found is over the 2 sessions, people got used to expecting it. And in fact, they got better. I mean, they quickly reduced the amount of feedback they were getting. And so as long as I think there's an initial warm-up period where you maybe get used to using the system just in, in some non-patient care environment, just to make sure you're comfortable with how the system's going to provide its feedback, that shouldn't be a concern. Yeah. So with
Tilak,
version 1,
Tilak,
sorry, go ahead.
I just wanted to go back to that question
Please.
around for in-home caregivers. Are you looking at a new environment? If the ultimate purpose in this is it's a tool to help with training instruction, to help reinforce training instruction. So if you extrapolate that, if people have learned how to bend properly, have proper body mechanics, would they then need that for every new environment?
Yeah, great question. In what I think what we see is that they do. It's sort of like each challenging setting, it kind of requires a new kind of problem solving, like to go through this kind of problem solving stage where you're faced with this particular constraint of here's the toilet, here's the bathtub in this particular person's house, and you have to work out the potential solutions to that problem in that space. And so, if you do understand what you're trying to do if you're trying to avoid spine flexion and trying to lean on hip hinging, you can work that through while you're doing the, kind of learning in a new environment. But having PostureCoach might help in that scenario, just to test out some different ways of doing it. And I think the feedback from it could quickly help you see which solutions might be the best ones in any particular scenario. Does that make sense?
It does make sense. So it actually serves almost as an audit function. So if you don't have your supervisor there, and you've been doing something consistently and they're not coming out to check with you, or you're the caregiver, you could put it on a few months later and it'll tell you, yeah, you're still on track, or you need to readjust.
Yeah, exactly. Yeah. I'm sorry, I'm missing some questions here. Feel free to, Catherine, if there's anything in here that I should jump into, let me know.
I will.
I'm happy to continue looking at questions. Yeah, I'll keep going here, but just, hit me with some more questions if there's anything that I should answer. So for this first version, we did a quick test with 18 people. 6 of them had no experience in patient handling. 6 of them were OT, PT students, and 6 of them were very experienced with patient handling. And what the team found. So for example, this is a type of data that they found. So this is for the group that had no experience. And so the blue bars show the amount of time that was spent at a particular flexion angle. So if you kind of draw a curve connecting those dots, you can see before feedback, people were bending at, you can see where the peak of that curve might land somewhere around 30 or 35 here, or 40. And then you can see with feedback, it shifts that curve back. And then even after the feedback is turned off, you can see it stays shifted back and maybe even shifts back a little bit further. So this is just in a few sessions in a lab environment. The comparison to the other group, a clinician group, so this is people that have lots of experience with patient handling, they did not shift very far. But to start off with, they were already starting at in not doing as much spine flexion to begin with, so they didn't have very much further to go back. But if we compare across the 3 groups, you can see baseline and then following the coaching, you can see that we did see a change in the novice group and in the student group, but not with the clinician group, or not a significant change there anyways. That's what that's the data that we got out. We never published this because we questioned the quality of the data that we were getting. The biggest challenge we had with this testing, with this first version, was that these IMUs had a lot of crosstalk between them. So they would have a lot of noise, and they would give us really poor data, really, when measuring the amount of flexion compared to a Vicon system. So the blue line here shows what a Vicon measures when someone was flexing and standing upright, flexing their spine and standing up. And the red line shows you what PostureCoach version 1 was doing. And it really comes down to a lot of these IMUs. You know, there's a lot of wearable sensors out there that I don't think people look at this close enough for. It's something that I think is overlooked a lot, but the quality of the Kalman filtering within those sensors, that you take the data from the sensors and then the way you filter it matters a lot. And it needs to be filtered carefully and then examined and compared to a gold standard to see how well is it matching. And what you can see here is we were getting these crazy spikes here that did not reflect how the person was moving at all. And so we ended up getting a much more expensive IMU. For those who know the Extend system, we bought the chip that they use in the Extend systems in their IMUs, and tested it, and we found it was much better at following the gold standard measurement here. So, and the Extends company, they've been around for decades at this point, and they have put a lot of thought into those Kalman filters, and you can see the value. You can see that come through in the data, the quality of the data. So version 2 was a little bit more complicated looking because we were using these chips, and we had to quickly wire something up that could collect data. This was meant to be the lower sensor, and this was the upper sensor. And we had this thing that would log the data and have a little screen on it to talk to us. This was Mohammed Olia, was his master's project, and I think he presented on this at one of a previous CRE-MSD meeting. This was his study to look at this, to evaluate how well PostureCoach would work. He compared a control group of 10 people with an intervention group of another 10 people. The control, everyone was novice. They were all novices. So kind of the group was designed to be, you know, considering the home caregiver, someone who's thrown into a new role as a caregiver. Is this a tool that we could give them to help them with their with moving in safer ways, to reduce the amount of spine flexion they produce? In a second, I'll show you the activities that they performed. For each of the trials, there were 8 trials, and in each one they repeated the same series of activities. The control group just repeated over 2 days those same trials over and over again. The intervention group had a few other additions. They watched a video on some basic back injury prevention strategies. Basically, I'll show you what that entailed in a second. And then they had some trials where there was no feedback provided by the system. So the ones that are white here are trials where there was no feedback, and then the black ones, we had feedback. So anytime someone exceeded 70% of their max flexion, the device would beep or vibrate. And I think it was beeping in this case. I think we did it all audible beep for this study. And so that would vibrate, it would beep for these trials, but not for trials 5 and 8. And the final data comparison that we did was comparing trial 1 to trial 8 between the control and intervention groups. The training video basically tried to get across 2 very simple ideas. You want to avoid bending if you can, but if you have to bend, stick your bum out and hip hinge. And there was some, in the video, they demonstrated what hip hinging looked like to try to get that across, get the idea across there. This is what the activities look like. There was a series of activities getting people out of bed and getting them in and out of wheelchairs, on and off a toilet, a number of repetitions of this for each trial. I think there was maybe 3 repetitions per trial, if I remember correctly. And this is done in home lab, which is one of the simulation spaces we have here at the Kite Research Institute. So this shows you the type of data that we got. This is a histogram of the flexion, the percent of max flexion that people utilize over these trials. So the dotted line shows you what they did in trial 1, and the solid line shows how their histogram looked in after trial 8. And what you can see in the control group, there's not much difference. The numbers that we were actually comparing here, what we chose was to look at their 80th percentile and their 95th percentile values. So to see what those values were on this histogram. And where you see no difference really in the control group, you can see that those, both the 80th and the 95th percentile values on the histogram shifted pretty dramatically. So what that means is with the feedback in the intervention group, we were seeing people spend less time in flexed postures, in more flexed postures near the end, in the what we call end of range flexion area over here. Does that make sense? I hope that makes sense. So you can see we were able to reduce the 80th percentile value by 36% and the 95th percentile value by 29%. So that was done in 2 days, back to back. Then Megan was the next master's student to take on this project, and she used the same device, but instead of, and she kind of repeated what Mohammed did, but then added in 2 more time points at 2 weeks and 2 months to see what is the, moderate to long-term impact. Are we teaching people, is motor learning happening here? And we started to learn a little bit about motor learning thanks to, I think it was Mike Holmes at where Mohammed presented some of his data at a CRE-MSD event. I think it was Mike Holmes, or no, it was Steve Fisher. Sorry, it was Steve Fisher who made the comment that, with motor learning and biofeedback, there's a benefit to having a phased feedback schedule. And so we looked into that a lot more and recognized that we might have more benefits if we reduced the frequency of the feedback we were giving people to 50% on day 2. So the first day was the same as what Mohammed did. The second day, we cut back so that if someone exceeded the threshold, the first time they would get feedback, but the second time they would not get feedback. And the third time they exceeded the threshold, they would get feedback again. So only half of the time they would get this type of feedback. And the idea in the motor learning literature, what we learned is that if you want to shift people's behavior quickly, you want to give them feedback consistently, but you risk making them dependent on that feedback. In comparison, if you want to get someone to learn how to do something long-term, you want to let people try to assess whether they're hitting that threshold themselves some of the time. So and in this case, we chose half of the time. If you let people try to work to understand where that threshold is on their own for part of the time, but then kind of remind them with the feedback every other time, it makes it slower for them to shift behavior in the short term, but it leads to better retention of that behavior in the long term. And so what Megan found was again using the 80th percentile values and the 95th percentile values. The blue lines show what happened with the control group. And the dotted red line is the intervention group in this case. And you can see that we were able to shift their behavior pretty quickly in both cases, both on day 1. They come back at the end of day 1. They've kind of gone back a little bit to where they started, and then with more feedback, they were able to shift their behavior back a little bit more. When we turn off the feedback again, we see that they revert a little bit, but then when they come back at week 2 and month 2, they've retained some of that learning some of that motor learning. And definitely this is drifting back again. So it's unclear if we need to have some sort of refresher at some stage at the 1 month period, perhaps. Remember, these are all novice caregivers. So there might be a need for, doing some refreshers in here somewhere. But you can see that we did have a statistical significant difference here for both 2-week and 2-month time points. So PostureCoach version 3 just took the sensor that we had, the wired sensor that I showed you earlier. We made it wireless. Mohammed helped with that, but it was so expensive. It's like a $2,000 just to get the components. It was like over $2,000, and it just felt like this was like getting me enough funding even to just test this out, do some pilot testing with it was getting challenging. And like we figured no one would be willing to purchase something like this if our cost was $2,000. So we were really thinking hard about this, whether it was worthwhile. Then I had Dawood, who's a PhD student with me now, who said, I think I can, he has a lot of experience with designing Kalman filters. I think I can design you a Kalman filter using cheaper sensors. And so he kind of rebuilt this from scratch, version 4 that I showed you in the video. It's now at a $200 cost for us. I don't know what we're going to sell it for, but it brings it back into the realm of potentially making this a useful product that we could try to get out there in some form or other. So our next steps are to really do some more pilot testing now that we have this version working. We just got REB approval to test this with personal support workers working with Emily at VHA. VHA is a home health care provider. Yeah, our goal is to test this out with some personal support workers over the next couple of months, and we hope to learn a lot more about it. How does it charge? Good question. It has yeah, I think it has lithium batteries, so it has USB. It has a USB port somewhere that it gets plugged into to charge. How robust are they? Good question. We've dropped them and they're fine. Good question, and that could be part of our design. These are 3D printed cases right now, so stuff that we've done. They could certainly be made more robust, Troy, if needed. And probably they will need to be made more robust. We're thinking we will we'll do a run of injection molded parts soon if we can get. So we're going to collect some. I forgot to mention, we're going to collect some pilot data, the goal of which is to apply for a CIHR grant soon. And with that CIHR grant, we're going to try to scale up this evaluation much bigger. And to do that, we'll get some injection molded versions done and we'll design them to be less breakable than the current versions. Yeah.
Tilak, I had an earlier question. It was related to the quality improvement from an employer's standpoint.
Mm-hmm.
Is there a way to know who the employee is who would be using this tool, who's obviously undergone training, but then the employer could go back to this employee or other employees and say, okay, we need to regroup. So is the wearable connected to an ISBN number that the employer would know who's wearing it? And obviously the employee would have to be comfortable with that. It's like having the supervisor on site watching.
Exactly. So there's some ethical issues there. Yeah, I mean, ultimately how we market this, it could be something to look at adherence, but I would really hesitate to go down that road. It really, we have an analogous project here at the hospital looking at hand washing and hand hygiene. And so there were basically badges that people would wear that would detect how often you're washing your hands. And I can tell you that no one would be willing to wear it. And they would, if you connected their name to the data, they would not wear it. They would find ways to break it and lose them. And, I think it's really tricky to go that way. But working in a group, if you label them as like, this is team, unit, whatever, or group region, whatever, here's the aggregate data for a given region of people. I think that's probably a more reasonable way. And as a team, we're going to try to learn how to do this, and we're going to try to achieve a certain target or something. You might be able to get more buy-in from that perspective, would be my gut feeling on that.
Thanks, Tilak. We've got a lot of exciting questions. Is there anything else you wanted to share before we get into these?
Yeah, sorry, I'll just say my last bit here, just acknowledging the funding on this. Again, the latest funding we've gotten, thanks to CRE-MSD on this, for the seed grant that we're working with right now. Previous versions of these have been funded by AgeWell, Canadian Frailty Network, Institute of Biomedical Engineering at U of T. All of them they were kind of $15,000 to $20,000 grants, and it's helped us keep this project alive. So we're very grateful to each of those. And to Mike Holmes, I want to say thank you to him. I mentioned his name earlier, but it was in what he helped with was a first test of version 1, where he highlighted the issue, that problem that I highlighted with the first version. So yeah, thanks to everyone. There's been a big team of people working on this and helping us push it forward.
Thank you so much, Tilak. We have lots of questions here, lots of engagement. So I'm just going to throw some out there. And one of them has to do with other non-healthcare settings. Has this device been tested or studied in other industrial settings like warehouses or manufacturing facilities?
Yeah, exactly. So that is part of the question, where do we start with this is part of, and that's a great question. I'm close to this from my previous work in healthcare, looking at problems in healthcare, but you're absolutely right that it has potential in any field where back injuries could be a problem.
Okay. And the big question here, interestingly enough, related to training, how much time and feedback is needed to have full behavior change with no need to refresh?
Yeah, exactly.
I'd love to hear your answer on that.
I don't have an answer on that.
A trick question.
Yeah. I mean, it's really hard to do these kinds of studies. I can tell you, even in Megan's study, where we did follow up after 2 months, we had dropout in participants. It's so hard to follow a group of people, it's like, over a period of time and get them to come back and be measured over and over again. And so we need I'm hoping that if we get this CIHR grant, part of this will look at the long-term needs for refreshing. We don't know the answers to those questions yet.
Hardware question. So sometimes workers have something else that they're using to support themselves. Will a gait belt worn around a caregiver's waist interfere with this unit?
No, I don't. I think that's a great question. I don't know. And part of me wants to think, can we build it if people are wearing certain other things? I think someone was mentioning earlier to me about these exoskeletons. I think BHA is testing out some exoskeletons, and I could imagine if there's something else that someone's wearing, to have this built right into it could be one approach. Yeah.
Are there long-term effectiveness of PostureCoach? You've shared some early testing, and are there similar concepts in person-patient transferring?
Yeah, long-term, we don't know. Yeah,
Right.
I mean, yeah, I think that's the area of research that we need way more work in now, and we're trying to find a way to get there. Yeah.
Have you thought about using this or talking to physiotherapists? Like what other practitioners have you engaged with?
Yeah, we talked so the first version was developed with a physiotherapist from St. Elizabeth Healthcare, and it was a workplace, someone who's involved in their workplace health. It was in conjunction with their workplace health and safety group, and definitely we need more. Yeah, so the people we get the biggest interest from with this so far has been people that have struggled with back pain, they want to use it for themselves. And so the return to work kind of group is probably one target area, and they're working with physios in that are involved in that kind of area would be a good thing to do. And we haven't explored it very well yet. Most of our stuff so far has been focused more on the novice user, people at the early stages in their career. But you're absolutely right. That's where we could go.
One of the other areas is, working with WSIB to look at their claims data. So we know that healthcare workers who are involved in a lot of back related tasks are prone to MSDs, and looking at some other industries where you're finding similar data.
Yeah, that's right. Yeah, I think if there's a return to work strategy that it could involve something like this, if there's a movement retraining component in there, connecting PostureCoach into that, it would be great to see if there's any benefit there.
Curious to know how this would be like back braces worn in Home Depot stores, which seem to provide a false sense of security, but not actual, preventing injuries. Have you had any thoughts around that?
It's a concern that we've thought about as well. Once you think you're doing, I guess the benefit here is that you can audit yourself. Like you could think you're doing it right. If you don't have any kind of feedback, you can think that you've learned how to do this safely. But if someone doesn't watch you closely and say, actually, it looks like you're rounding your back, try it a little bit differently, try it like this. If someone's not there to do that, you could get that false sense of security from not having this. I would think that having that objective feedback from a sensor like this might help avoid that piece of it. But then once you feel that you're trained, could you slip back into a kind of your old patterns, perhaps? So there's still that risk, certainly, and kind of that overconfidence, like I feel like I'm doing this right. So, and do people, do people take on more? Do they start lifting heavier loads as a result of feeling like they are protected because of a particular technique that they're using?
Interesting.
Perhaps, yeah.
And that's a good segue into the training related to proper body mechanics, getting that comfort with people with the training and then using this device. Do you worry at all about a narrow focus overshadowing other important training aspects of proper body mechanics?
Yeah. This is really one component, and we decided to just, you're absolutely right. There's so much, if you consider that term body mechanics, there's so much to it. Talking with someone like Tyson Beach, he understands this. For someone like a firefighter, how do you move your body safely? How do you set up the space in front of you? Make sure you're not gonna, there's so many aspects to it. How do you turn your feet relative to your body? It's not just about, there's so many factors here that you have to think about. And the question, we're just looking at a really narrow slice of that. There may be lots of things you want to help someone get better at when it comes to body mechanics. This is one narrow component of it. But we just wanted to see, does a wearable device like this have the potential to improve the way we do training?
An interesting comment and a big dilemma in a lot of industries has to do with the experienced worker and trying to retrain and maintain that training. And again, I'm wondering about your CIHR grant application. Could it be an opportunity to look at a group of experienced workers versus new trainees, and the efficacy of this training and the longevity of it lasting?
Yeah. So that was how, so we put in a CIHR grant in 2019. It was turned down, and the reviewer comments, one of them was, so what we, and in that initial, sorry, I'll back up. In that initial application, we had listed, I think, 6 different groups of workers, and yeah, it was like experience, based on experience level, based on back pain, experience with back pain, trying to separate out these different groups. I think we had paid workers versus unpaid caregivers, as well as groups. So I can't remember exactly how it all broke down. But one of the bits of feedback we got was, you're looking at too much here. Like, there's too many different groups. You need to narrow down and focus this grant. I disagree with that, frankly. I think what we need is a quick and dirty test of all these things, and then we would actually see where this thing has potential. But I think that's just not the way CIHR kind of is targeting. They like big studies around narrow focuses. So what we've decided to go with is the personal support worker group. We may still have 2 groups, one that's people without any kind of pain, or people maybe new to the job, and more experienced people. As you say, we could have 2 groups perhaps that we'll look at.
And that would work well with that occupation, because we do have a very high group of older workers who have been there for a long time. Our challenge in that industry, or this industry, is getting the newer, younger worker in. So you could have a natural sample there for looking at those variables. One of the questions is around frequency. We know that repetitive work, the frequency of the tasks that we're performing, and workers in the PSW industry try and shake that up because of the impact. Does this tool address anything related to that?
Sorry, can you just say the beginning part one more time?
The tool, so we're wondering about the frequency
frequency.
of a task, right? So it's an issue, and we try and shake up that so that the worker
Yes.
isn't consistently performing that same task, wear and tear on the
Right.
body.
Thank
Is there
you. Yes.
something that this tool can do?
It can
to
track,
help with
well,
that?
it can track it. So yeah, I mean, I think that could be one of the biggest, even if the prompting piece didn't exist, right? Even if we didn't give the feedback, just having something that could accurately measure how much flexion someone is going through over the course of the day. How many times are they flexing their spine, so that we can get a handle on what is the exposure, what is the risk that that person is experiencing. I think that in itself is a potential value of this device. So you can just put it on someone, let it collect data for 8 hours over the day, and look at that, and then say, maybe this person's job should be reorganized in a particular way. Yeah, that's a great idea.
And I think we'll wind up this wonderful presentation with the very practical question. This device and many other devices go missing.
Yeah.
Is there some kind of a tracking mechanism that I'd wear or built in so I can find the device?
I mean, that's a great suggestion. That's a great, I mean, we
Makes me
could
think of our air tags that we
tag
buy when we're going away, right?
yeah. Should we just put an air tag in the right? Yeah, that's an interesting idea. Yeah, thank you for that suggestion.
All right. Well, Tilak, I want to thank you. This has been a really, really engaging, especially on a new platform for us today. It didn't seem like we had any glitches. And if people did have glitches in any aspect of this Zoom platform, if you would email Bettina, and she'll share it with the rest of us. I'd like to thank Tilak for coming to share all you've learned on these versions, and to encourage people, if you have ideas or pilots that you would like to carry out related to preventing musculoskeletal disorders, we have seed grants available. We can hook you up with researchers like Tilak and other researchers in our network to test these things out. And we look forward to hearing from you. We have another webinar coming up on November 12th, Visual Ergonomics, Lighting Design and MSD Prevention, something that cuts across every single industry, and I'm sure we can all benefit from learning from this webinar. Hope to see you there. And again, thank you, Tilak, so much. Really fabulously engaging webinar.
Thanks, everybody. Thanks for joining us.